yesterday we did a lot of work on data and pulling data together. So today it's something a little bit different. So and it's critical appraisal. So if you remember what we talked about yesterday, we think about the not yesterday, but the day before, we think about the research question very carefully, and that helps you set your eligibility criteria, then your search strategy, and as a result of your search, you end up with the studies that you want to include in your review. And once you've got your pool of studies, you read those studies, you extract data, and ideally at the same time, you want to critically appraise that paper. And in reality, you will need to read that paper more than once. And I always say, do the data extraction and critical appraisal together, but papers are not always easily understood. They don't always report their findings very well. So in reality, you probably have to read that paper 2 or 3 times in order to get all the information you want out of it. So today we're going to focus on the critical appraisal part, which is critical. So this is what we're going to cover today. We're going to discuss the purpose of critical appraisal in the context of systematic review. I'm going to talk about the criteria that are commonly used in critical appraisal of experimental studies and observational studies. So randomized control trials and observational studies. I hope that at the end of the day, you'll be familiar with critical appraisal tools. And I mentioned briefly the other day, there are lots of tools out there that can help you with your critical appraisal exercise. How you report the results of your critical appraisal and specific to the study type. And also identify different methods of reporting appraisal results within the systematic review. One thing that people often ask is, what do you do with the results of critical appraisal? It seems such an isolated exercise. Often people do the critical appraisal and then they go on and do report the systematic review and do the meta-analysis without real connection between the two. Maybe a sentence to say there's good quality evidence or it's poor quality evidence. So there are ways that you can incorporate the two together and have more meaningful discussions. So have you heard of this, GIGO? Yeah, garbage in, garbage out. So this is really, really important because if you remember, in a systematic review, your papers are like your data. So if you're doing a randomized control trial, these are your patients. So if they're not of good quality, if they're not fulfilling your criteria, it doesn't matter how sophisticated your meta-analysis is. You can be doing multi-level regression, really complex analysis, adjusting for all sorts of things. But if your source data, if what you start with are not of good quality, are not relevant, then there's no point. The results will not be meaningful or relevant. So it's really important to think about what the nature of your data, the quality of your data, and whether they are compatible in terms of for meta-analysis. So critical appraisal, I think it's really important to think what the objective is and what it is you're doing. So critical appraisal is the application of critical or analytical thinking and knowledge to assess publications against an identified criteria. So if you're going to end up by saying that this paper is not of good quality, you need to justify it. Equally, if you think this is a really good paper, you also need to justify it. So you need to have predefined criteria in terms of how you define good quality or poor quality, so that you can report this in a transparent manner. It's an essential element of evidence-based decision-making. So it's not just having evidence, having good quality evidence to influence your decision-making is important. And it's an essential element of systematic review. So it's active and not passive. It's thinking and not assuming. So it requires critical judgment. So judgment is really important here. It's also very important to remember what critical appraisal is not. It's not the art or science of trashing papers. sometimes people get into a really critical mode, and the objective is really to pick the paper as much as possible. So it's not really about that. It's about giving the paper a fair judgment. And when you're critiquing something and reporting on your critique, there is no reason to be impolite or uncollegiate. Often you see reviewers being quite aggressive about poor quality studies. So there are lots of reasons why a paper is not well reported. So what you need to remember is, when you're critiquing somebody's paper, when you publish, somebody else is going to critique your paper. So critique it with respect in a manner that you'd like your work to be critiqued. It's not an exact science, as I said, it requires judgment. So really, predefined criteria and transparency is what is going to help you through this. And it's entirely subjective. So what you consider good quality evidence may not be the same as what I consider good quality of evidence, especially when you get down to the individual criterion, because primarily it's because of poor reporting. So this is why in systematic review, especially this step of systematic review, it's really important to have two people doing this, so that if you have a disagreement or divergence of opinion, you can have a discussion about it and try and come to a consensus. So here are the standards of reporting, and I've shown you some of this already. And these guidance basically tells us what good quality studies ought to look like. So if you're familiar with these guidance, then you have a really good sense when you read a paper, without even having a checklist next to you, whether it's a good quality paper. So the consort statement, consolidation standards on reporting trial statement, that's for randomized control trials. And you have to remember this statement was written in the early to mid-90s. So sometimes when you're reviewing randomized control trial from before the consort statement was set up, naturally they would be of poorer quality, purely even just based on the reporting, because the standards then were not the same. The stroke statements focus on observational studies and epidemiology. So if you're doing a systematic review on of observational studies, cohort studies, for instance, then it's a really good statement to guide you. Transparent reporting of evaluations with non-randomized studies, a trend statement, it's designed for public health type studies, before and after studies, non-randomized studies. And the PRISMA statement, of course, is to judge the quality of systematic review and meta-analysis. And the MUHTA statement for meta-analysis of observational studies. So these are really, really good guidance to give you a clear view of what good quality study ought to look like. And the checklist that have been developed to assess quality typically stem from these statements. Now, this is a very good source of information, the Equator Network. And the Equator Network, it basically consists of a database of guidelines for assessing quality of studies. So as you can see, individual study types, randomized trials, observational studies, down to clinical practice guidelines. And here are some of the statements and guidance to tell you about good quality for assessing quality of study. So I think this is definitely a source that you should recognize and use. Now, in terms of the PRISMA statement, how on reporting the quality assessment or risk of bias, this is what they say. So the PRISMA statement has 27 items, and within the 27 items, under methods, it says that you need to describe methods used for assessing risk of bias of individual studies and how this information is used in the data analysis. So it's very clear for good for a systematic review to be considered good quality. You need to assess risk of bias, but you need to be clear about how you assess this risk of bias. Specific specify any risk of bias that may affect the cumulative evidence. So under the methods section, we expect to see something about how you're going to approach this. And then in the reporting and the results of your systematic review, we expect you to present data on risk of bias for each study. So we talked about briefly the other day how some of the checklists give you a total score. It's not enough to just put an average score or total score up in your review. It's important to present data on risk of bias for each study. And also assessment of risk of bias across the studies. So this is what's expected in the results. And in reality, the recent development is really to encourage reviewers to report risk of bias based on outcomes, because you may be interested in more than one outcome in your systematic review. And each study reporting multiple outcomes may have different levels of risk of bias depending on the outcomes they're trying to measure. So recent movement in systematic review is actually to go that one step further, not to limit it at study level, but at the level of outcome reporting. And finally, in the discussion of your systematic review, you need to summarize the main findings, including the strength of evidence. So you may conclude that there is a statistically significant treatment effect, an odds ratio of 0.8 for risk reduction. But what evidence did you use to generate this estimate? Was it based on good quality evidence, or was it based on poor quality evidence? How much confidence do you have on this estimate that you have generated? So you need to give some indication. You need to discuss limitations, including risk of bias and reporting bias in your discussion. So the prisoner statement is really, really good because it does set out very clearly how to write a really good systematic review and meta-analysis. And these points that I've shown you here particularly relate to quality assessment or the assessment of risk of bias. So with quality assessment and risk of bias often are two phrases that are used interchangeably. But in reality, what we really are looking for is risk of bias. We want to know that the ultimate treatment effect that you have estimated, how robust is it? Is there potential bias that could have influenced it? Are you overestimating or potentially underestimating the effect that you're interested in? So here are two definitions for bias. Any trend in the collection, analysis, interpretation, publication, or review of data that can lead to conclusions that are systematically different from the truth. And the other definition from the Cochrane Handbook, a bias is a systematic error or deviation from truth in result of references. So I think they're both basically more or less talking about the same thing. So this is how bias are defined. So if you think about randomized control trials, these are the sources of bias that we're looking for when we're assessing risk of bias. Selection, performance, detection, attrition, and reporting bias. And there may be other types of bias depending on the specific trial design. Now, selection bias. So selection bias happens when patients are selectively enrolled into a particular arm of the trial. So if you selectively enroll more healthy patients in the treatment arm compared to the comparator arm, then you will have an exaggerated treatment effect. So this is why randomization is important. Appropriate randomization would avoid this potential bias. So selection bias when randomization fails, and also when allocation sequence concealment fails. And this would result in systematic difference in baseline characteristics between their arms. So the way that you can look for this is look for how they randomize their studies and look at the normal table 1 of the randomized control trials to see if between the two arms the characteristics are evenly distributed. So in terms of randomization, what we would consider adequate randomization are computer-generated random numbers, the use of random number tables, drawing lots or sealed envelopes, throwing coin tossing, throwing dice. So these are all random a process of generating random numbers. But normally nowadays we expect computer-generated random numbers in a randomized control trial. That's really what you would expect. So what we don't accept is if the patients are allocated by case number, according to the date of birth, the date that they turn up at the clinic or the hospital. They're randomized according to the days of week. So if it's Monday, you go to one arm. If you come in on Tuesday, you go in another arm, which is basically alternation. So these are not appropriate randomization. The tricky thing here is not all papers will report this level of detail. They will say they randomize patients, but they won't actually say how they randomize the patients. And then you have to make a judgment here. Is it a reporting issue, or is it that they actually didn't randomize accurately? So randomization and allocation concealment. So it is considered adequate if a priori numbered or coded in identical containers, central randomization is done off-site and it's in sealed opaque envelopes. So that even the person who's allocating the treatment does not know which arm the patient's being randomized to. It's inadequate to have a list of random numbers, non-opaque envelopes, anything that allows the investigator to foresee or interfere with the upcoming assignment. So if somebody's been randomized to a control group and somehow there's a mechanism for the clinician to find out and decide that actually I don't want my patient to go into the control group, I want my patient to go into the treatment group. So that's just some of the examples. In terms of performance bias, what we're talking about are systematic difference in care provided between arms. So this happens when patients are not blinded or when clinicians or personnel within the trial are not blinded or both. But the problem is blinding is not always possible. So in some investigations, it is inevitable that they have to violate performance bias. So can you think of some examples when blinding is not possible? Surgery. Yeah, absolutely. So surgical trials are almost impossible to blind because it's unethical to give a control group a surgery. The other thing that people often think about is acupuncture. Now but nowadays, in acupuncture trials, we expect them to have a sham group. So instead of not receiving acupuncture, it is entirely feasible to give people fake acupuncture. So I don't really know the details, but I think it's related to the depth of the penetration of the needle and also to have acupuncture in non-specific pressure points as well. So it is entirely possible. So that is the best way to deal with blinding of acupuncture. So if you look at the literature, you'll see a bit of a mix, but the more recent literature goes towards a sham comparator. Okay. So blinding is basically concealing your allocation. So if blinding is not done well, then randomization will be broken because you know what you're getting. So the method by which patients are allocated to either the treatment or the control group must be adequately concealed from the clinicians conducting the trial, so that it cannot be interfered with. Detection bias, a systematic difference on how outcomes are determined between the two arms. So outcome assessors do not know which treatment the patients are receiving. So in a lot of the cancer studies, for instance, the determination of progression is based on an independent review committee rather than the clinicians treating the patient. attrition bias is systematic difference on withdrawals between two arms. So exclusion of patients and data. So when patients leave the trial, when they drop out for whatever reason, it should always be recorded and reported. So if it's not reported, then it will lead to incomplete outcome data being reported. And it's really important because there are many reasons potentially for attrition. It could be because the treatment's not working. It could be the treatment is leading to high level of side effects. And these are all relevant for, to the study and for the treatment effect you're looking at. So if it is because the treatment is not working and the patients are leaving, and they are all excluded from the analysis, again, you're going to have an exaggerated treatment effect. So this is why it's really important to report dropouts from the trial. And it's also important to report it. So it's important to make sure that the design has been done in a way to try and avoid people dropping out. And it's also important to report how it's done. And at least, and the reporting is important. Total transparency is important. And also, especially in intention to treat studies, you expect them to include everybody who's been randomized, even though they drop out halfway through the trial. So that's why it's really important. There are other potential biases that may be possible. So if there's crossover in the trial, so you may have a treatment arm and a comparator arm, and then at one stage, the people in the comparator arm stop being in the comparator arm and start receiving the active treatment. So they cross over. And so if that happens, you need to adjust for that in your analysis. So carryover effects in crossover trial could be potential bias if it's not adequately adjusted. Recruitment bias in cluster randomized control trial. So in cluster randomized control trial, that's when individual sites are randomized rather than individual people are randomized. So if you have uneven recruitment in different clusters, then potentially it could lead to bias. And also contamination when experimental and control interventions get mixed up. So this could happen in a lot of the trials done in a community setting. So if you recruit patients in a GP waiting room, they all talk to each other. So if it is some kind of educational intervention, the control group patient might be sitting in the room talking to the patients receiving intervention. So for instance, if it is exercise, increasing activity, they might think, well, actually, I'm just going to go and do that. It looks like it's doing well for you. So there's contamination, and it affects the estimate of treatment effect. So this is, again, a potential source of bias. So the most commonly used for assessing risk of bias is the Cochrane's risk of bias tool for randomized control trial. And as you can see, the main domain that they assess are the ones that I've just talked about: selection bias, performance bias, detection bias, attrition, reporting, and potentially other bias. So this article in the British Medical Journal gives you the detailed definitions of what they mean by these bias and potentially what the scenarios might be. So this is definitely a good source of information, and I won't really go through the table in detail. Now, there is very, very recently, as you can see, October 2016, there is a version 2 of the risk of bias tool. So this is the revised Cochrane risk of bias tool for randomized control trial. So it's an improvement based on the previous version. So if you're doing a systematic review for on randomized control trial, I would recommend this is the best tool for you to use for assessing potential risk of bias. So let me just show you, give you a bit more detail on the risk of bias tool. So very short video describing the risk of bias tools.
And then subsequently had a minor revision in 2011, which was then published in the BMJ. So this is what the tool looks like. So this is an example of a completed risk of bias table for the review: foam dressings for venous leg ulcers. As you can see down the left-hand panel, we've got a number of different sources of bias that need to be assessed, author's judgment for each source of bias, and then any support that they have for that judgment in the form of, say, quotes from the actual publication, and then their interpretation of whether that is a problematic method that was used or not. And so you often see in Cochrane reviews a table like this for all of the studies included in the review. So the current tool includes 6 sources of bias that are assessed by default, with an optional other bias domain where people can raise some other issues that they have some concerns about. And for each source, users have to provide some free text to describe what actually happened in the trial, and then provide a judgment for each of those domains, whether they think that domain is at low risk, unclear risk, or a high risk of bias. And some of you may know that within the tool itself, some sources of bias can be repeated for different endpoints. So for example, in some of the reviews that I've worked on in the past, I've tended to divide the blinding of outcome assessment domain into 2 rows, one for subjective outcomes and one for objective outcomes. And so that applies to all of the studies included in my review. Now, the current Cochrane risk of bias tool is very widely used. So in an evaluation of the tool done earlier this year by Lars Jorgensen and colleagues, published in Systematic Reviews Journal, they had a look to see how often it was being used, and noted that in 100 Cochrane reviews published in 2014, that the tool was being used in all of them. But it was also being used in about 38% of non-Cochrane intervention reviews as well. They also noted that to date there's been about over 2,500 citations for the current tool in non-Cochrane sources, so it's very widely cited and it's been quite influential on the assessment of risk of bias in trials and methodological research as well. But since it was launched back in about 2008, 2011, the scientific debate on risk of bias has continued and evolved. So a number of different other risk of bias tools have been developed, which are structured in a slightly different way. The empirical evidence for different sources of bias has accumulated as well. And also during this time, there's also been a number of evaluations of the tool. So Jelena Savovic and colleagues in 2014 published a survey of Cochrane review authors and results from some focus groups on how users actually find the tool. And we've had a number of inter-agreement or inter-rater agreement studies, for example, done by Lisa Hartling and colleagues, to name just a couple of them. And in that same paper done by Lars Jorgensen and colleagues, they actually looked at the actual use of the Cochrane tool in published reviews. So that is how often studies are rated at low or high risk of bias, and what sort of new domains are being added to the tool, or which ones are being taken out of the tool in actual practice. And so what all these evaluations have found is we've found that there's a number of issues with the existing tool. First of all, we think that sometimes the tool is used a bit simplistically, and you sometimes might hear people say that they can do a risk bias assessment within 5 to 10 minutes, and in that case they may not be actually thinking through all the issues in a careful, comprehensive manner when applying the tool. We often find that it can be used inconsistently, so some of the core domains are dropped from the tool in some reviews, and some new domains are added which are not necessarily related to bias. So some people will add an issue of sample size to the actual to all their risk of bias tables, which has a lot more to do with precision than bias per se. The inter-rater agreement studies do tend to find that there's modest agreement between 2 raters on the tool. We also found that only about 5 to 10% of trials in Cochrane reviews actually scored at low risk of bias overall. And possibly one reason for that is that there tends to be an overuse of the unclear risk Now, sometimes for some of the domains in the tool, particularly incomplete outcome data and selective reporting, some users keep telling us that they just find those domains particularly difficult and that they need a bit more guidance in order to assess them. There are some particular challenges with unblinded trials where we do hear time and time again from people who tend to work on interventions where it's just not feasible to blind people. They just a bit, I guess, uncomfortable with the idea that all of those trials that cannot blind people automatically get rated at high risk of bias due to that lack of blinding. The current guidance for the current tool also is generally best suited more for your standard parallel group trials and not as well suited to crossover or cluster randomized trials. And in general, there's not really a standard, very well systematic approach to reach an overall risk of bias judgment for a particular study. When you consider all of the domains together, what's the overall risk? And while there is some guidance in the handbook about that, it's not necessarily followed that closely. So my collaborators here in Bristol were fortunate enough to receive funding from the UK Medical Research Council network of hubs for trials methodology research to start a project to revise this tool for randomised group trials, which we're calling currently ROB 2.0.
Okay, so that was the motivation behind introducing the new tool and highlighted the limitations of the old tool and inconsistency between reviewers and the use of unclear risk of bias. So this is something that you see a lot. People end up sitting on the fence rather than make a judgment. So so I think that was a really important point from that video as well. Okay, so I think it's time for you to do a little bit of work. I know that this paper has been circulated already. This is a paper published in the British Medical Journal in 2000, a randomized control trial of problem-solving treatment, antidepressant medications, and combined treatments for major depression in primary care. So, so what I would like you to do is to get into groups of 4s. So, and think about the domains when assessing risk of bias that I've talked about earlier, and give a judgment. So so I'm going to give you 15 minutes to get together and talk about whether you would consider the study to be high, moderate, or low risk of bias according to those domains. So so are you okay to group yourself into 4s, or do you want me to help you do that? Yeah?
We will go 4.
Yeah? Are you happy to do that? So first 4 here, and then 4 down that way, and all the way around. And if it doesn't equally split into 4, the last group can have more people.
So what is group 1? Group 1 for you. Okay. Let's sit together. Sit in a group. Group 2, right? 6. You want to separate in 3? How about 5 and 5?
But splitting into the thing also.
You need to tell them what to do.
Okay.
Otherwise, it's like,
It's just funny which one is the biggest.
the culture.
Yeah.
And some students. So we need to force them.
I force people in the class and they look at the class. What I sometimes do is I younger ones get together and then they sometimes I'll say if they want to do it so I want to so give them more flexibility.
Just making him
Like that.
It's a major depression with score more than 13. Patients with more than 13. Patient aged the whole disease. Depression score of more than 13 to this patient MD more than 13 to more than 13.
Major depression,
Two classes this morning. We just teach one class and then we're gonna teach the first one is patient safety and the other one is clinical industry. So
Very different.
Yes, I just go that okay, you do the exercise, we come back later and then we give a lecture in this room and then okay, do the exercise.
That is multitasking. That is very impressive.
Okay.
the first just last time. Just type manually.
Okay, so what are we discussing here?
We're starting with PICO.
Pico and then we will use the criteria.
Okay, so what are you assessing this paper against? So we talked about the domains that are up there, we talked about randomization, allocation, concealment. So is PICO going to help you? Does PICO help you with randomization? No. Okay, so let's deal with randomization first, okay? So what does the paper say about randomization?
Randomization, how do you outcome?
I think then randomized by
Yeah.
even though it's randomized with random number, so it's loaded in randomized generation.
Now, so they mentioned that there is a concealed, they are putting some
And about the
thing, but
yeah.
how much clear, like it's like completely opaque sort of thing that they are not clearly mentioned, but they mentioned that they mentioned in a like concealed C.
Okay.
So that's what
Okay, so
they
you
mentioned.
deal with it, randomization and allocation concealment together, that's fine. So are you quite satisfied with the randomization and allocation concealment?
From the table, random number is low list. It is indicated that we use the computer. That's what I think in the previous relation. So I think
Okay, so collectively, are you making a judgment? So for randomization, are you saying it's low risk of bias? So what about allocation concealment? Do the patients and the physicians know what they're getting?
The thing is that information is not clear, and also the kind of information. Yeah, and also the intervention is in such a way that because it involves that questionnaire based thing. So that intervention, like what is it, problem solving treatment. So I think even the procedure itself is not able to clearly kind of blinding is may not be possible in these kind of scenarios.
So I think I need a discussion with the four of you and jot down what your conclusion is, and then after that move on to the next risk of bias. So I don't know if PICO is going to be useful here because you're assessing according to very specific criteria. Your criteria are the 6 criteria listed. Okay, so jot down your decision.
We just go ahead into this criteria. You shut it down. No, we just go with this.
I think there is many forms of relation
So we're going to the slide.
first one is selection bias. So low risk bias is referring to a random number table. So they use random number table of random number table.
and then we are going to the track negative. So we can look around
It's a surprise. It's not going to tie me up to a tree. It's not that adventure.
And
Yeah, they will not do that. I think so too. Oh really? Yeah, did you see it? Yeah. But we looked at it when we came out of the talk. Yeah. And then the eclipse public talk, and we had a good look around it. It was very cloudy. So, and then we went for dinner, and by the time we came back, it was quite late. So,
allocation supply.
so we went to a restaurant in the Paris. So in the basement, it was a
So
Paris.
because in randomization thing, they also mentioned that again at the next step they did stratification. What kind of like randomization is done at one time you have to we did this assignment.
But it's not one down.
Usually the first mention is a random number table. Because the randomized like total population, but after stratification is not clear. You got my point, right? So because there is some doubts about.
It's just, it's just.
I mean, do they were randomized the whole sample and that gets subgrouped.
Definitely came here, but I don't remember which one. I remember it
Because the
was
mission is randomized strategies to ensure that all technical groups are very descriptive. So here it looks like there is some kind of increasing bias over here because
Bias allocation for treatment will also made by research.
making more software approach.
Treatment will made by research workers. Separate forms, assessor, therapist. Using card.
You're very great.
So even the therapist, they don't know.
I thought it was that big. So my alumni was very fun actually. They gave me a present and it was a small wallet, but it's shaped like a jewelry. It looks like a jewelry. It was so funny. It's like a jewelry. No, but it looks very much like a jewelry, and and you can feel it. It feels like a jewelry. It was so funny. I looked at it. Oh my god, it's a jewelry. Yeah, it was just so funny. We just laughed. She didn't. Because I was kind of because I supervised the project when she was in class. I don't remember. I remember my auntie started talking. And she was doing also so PhD. But she was really nice. And once I started talking, I remember it was nice
อันนี้มันอาจจะแทน where to stay the first really group of people and then you know was a people
they remember you.
I tried to was the happy and we call verbal by and also when we call it number one
I chatted to, he's working with the guy. He's working with somebody else.
he's very talented he's quite irritating
So he was also
he's already actually he now this is the portion for just like when you learn to survive he hasn't come like that so long and this is In the definition of the bias, there's no but the review from order that's the that the patient is medicine or counseling but
I think the blending is largely at the part of assessor, those who are assessing, but blending is not blending the patient, because patient knows what treatment is getting. So that will definitely may induce some kind of, because I'm getting two treatments, I may have better. That's both drugs and whatever the questionnaire things. So it looks like there is in performance, I think, there is some bias on the patient side. May not be on the officer side, as per what they mentioned.
they have low risk, high risk, and clear risk.
It looks like high risk.
That's why initial confusion, but other food on the so you has to and it's look
Detection
So, you can choose this option or we can find that. So it's random by is it the only person?
Both of us is
that will also influence the same.
allocation to consume. Is it a low risk or is it high risk? Allocation to consume.
Yeah, it's low, no risk.
That's not high so it's very complicated. But about the consumer mentioned that
I use of packaging without all safeguard. So I think they have used it. They have used it.
in the paper they say that they using gas in seal envelope. They don't say that okay envelope. So they cannot consume that. I think it's okay.
Look, there is some, appears to be some low risk. Some risk is there in that, but no risk you can mention. Detection that both performance and detection almost to with high risk together
But in this study, the outcome measureแต่ว่าอันนี้เป็นmeasure
concern about the education things. Thing is, like 3 groups of subjects. One group of treating and one group of assessing. Even those who are treating are they blind? Because the both doctor and nurse were giving the because there is no shadow.
You want to add?
Yeah, first one finish one and then that is one round we finish fast. And that is fast.
Admission and reporting.
So which domain are you on? London. I'll give you a bit more time.
Because of no reading.
Score assessed by physician that so this is okay of the like physician but about the patient score like how to score is assessed by patient so they assess themselves and they know what they should do but I think it's not because some different outcomes
I always debated in both because that question is kind of that question asked is in such a way. Secondly, that the distribution code is scored by the patient improvement. It's like subjective state of improvement. But in a way, because you want to do like too stringent, then disappear. Okay with kind of because one more word you mentioned is kind of naturalistic outcome based RCT. I mean like what usually happens in clinical setting. If you consider in that mode, then it is okay. That kind of assessment. But still
John mentioned that assistants were made by one of the two experienced interview who were blind to the type of the treatment given. They don't know that.
next paragraph.
Assistant, I don't think we really bias involved.
thinking about in terms of like the treatment schedule. First they started with paracetamol and then they changed to the treatment is not uniform even the treatment. Really, what was thinking of over 100
I just love that question. Oh, really? Yeah, I want to buy more of this. So how?
to consider the overall thing,
I think
whether it's a low risk.
Where do you get it?
No, I would say moderate risk.
So I think I'll get one to myself.
It is always kind of
No, it's just, I don't want it's quite a lot cheaper.
Yeah, 3 kilograms.
straightforward thing.
But let me pay for it.
Maybe in artificial thing, you know, definitely.
I only want 3, I don't want more than 3. No! I can't carry 10. 3 would be
Okay, if you got
negotiate. Okay, fine. No more than 5, because I will not be able to carry it. Deal. And I don't want to leave it in the hotel because it's very good. So 5. That's a compromise.
Information about all
Do you eat
all the outcomes and they are
every day? So they sell it, all of it.
totally go.
they do like a
Love that rice, it's so good. I make congee as well with it.
Yeah.
Yeah, because you said last time it was good with congee. So.
and if you put like some sugar in the congee, it's like a pancake. And we put like coconut milk, a little bit coconut milk. Yeah, it's before I
So you don't have to worry about travel insurance because my university covered it, so that's fine. So it's just the flight. So I have the boarding pass, but do you also need the boarding pass when you go back?
if you have it's not
So I will give you the ones on the way here, and then I can scan it when I get back. Yeah, with the rest of it.
and you have the receipt.
Yeah, I think I emailed it to you. I'll find it.
I think it's probably the folder.
All right, okay, I'll email it.
So we can arrange the budget
Okay.
for next week.
Right, okay, so I think it's time to hear your judgment. Now, I think it's absolutely great. I've gone around the groups, I can hear discussions, I think it's really, really good. But I've given you about half an hour and you've been discussing one paper. So if you're doing a systematic review on 50 papers or more, then you'll have to allocate a lot of time for risk of bias assessment. So, I mean, I'm not saying that you have to do this quicker, but I think for some groups, you need to make a judgment. So I think some of you are slightly afraid to make a judgment, so you spend a lot of time on one domain. So the good thing about having co-reviewers, so we've got different reviewers here, is you make a judgment and then you chat with your co-reviewer. So when you're doing a project, when you're allocating time, you've got 6 months. Think about how many papers you have, how much time you should allocate to the critique. Because it does take a long time to do a proper critique, but don't over-analyze it, because then you're going to get stuck in something. You're laughing. I can see that you maybe did you go through the same thing over and over again, and you made a decision and then you doubted yourself. Okay, so let's hear some of your thoughts. So the first domain is on. Let me just put up the slide. Okay. So selection bias. This is about randomization. I'm going to go to that group because I know that you've been discussing randomization. So what's your judgment on randomization? For selection bias, what was your conclusion? Is it high risk of bias, moderate or low risk of bias? Low risk. Okay, so how did you come to this conclusion? What did they do in terms of randomization?
For the random sequence generation, they stated that the allocation schedule was generated using a list of random numbers.
Mm-hmm.
And then for allocation concealment, they explicitly stated that the allocation to treatment group was made by using cards in sealed envelopes.
Okay. Okay, so you're quite satisfied that the two groups are randomly allocated, and in terms of results table, good balance and baseline characteristics.
At least based on their profiling, their baseline characteristics, their
Okay. Are there any disagreement in the room? Okay.
I would think that is unclear, because the paper only mentioned about the patient who were randomized without specifying any specific technique. And regarding the detail that using the list of random number, but that was used for the allocation, not for the randomization. So I will decide that this was unclear.
Okay. So I can see, I absolutely see your concern. But the ultimate question you're asking yourself is whether randomization has failed. So is the way that they have approached it, and also looking at the results table. Because I think part of this is to do with reporting as well. There's a lack of detail in reporting. So I mean, there's no absolute right or wrong answer here. It's a judgment call. So you need to remember that. I think in my view is given all the components that I can see, I was quite satisfied with the randomization, although the reporting could have been done a lot better, I absolutely agree with you there. Okay.
Just more concerned about the randomization, because they mentioned that they randomized for the whole sample in the beginning itself, or because they mentioned that they stratified. Because they stratified according to, because randomization done at what level, I think they are not clearly mentioned. So that is just a kind of concern. Because like once any patients come in, they just randomizing, and then how they actually stratified. That information is they are not provided, because their main aim is, though I think they may not have reported, but once they come, like how actually they stratified.
Okay, so again, I think this is to do with reporting, the detailed reporting. So typically in stratified randomization is done during the randomization process. So again, I think my take on this, having read the whole paper, is an issue of reporting. Now, in terms of issue of reporting, you also have to remember, when you're submitting a paper to a journal, most journals have a limitation in terms of the word count, right? So people generally don't want to cut the results, and so I think many times the methods suffer. So I think we have to have a little bit of sympathy on that. Now, one thing that you can do is, if you're really uncomfortable with the lack of information, again, you can try and contact the authors and ask them for more detail. Okay, so I'm going to move on to allocation concealment. I think Yen touched on that already. So Bhavani, Yogesh, I'm going to ask you guys, so what did you decide on allocation concealment?
Allocation concealment, or it's A low risk bias.
Low risk of bias, and
Yeah.
okay, and your justification?
Just to mention that it is like
Patients are randomly allotted by a research worker.
and a separate person.
And,
other than that.
And those who are separated from both the assessors and the therapist.
Yeah, so I think that's a really key point here, that the allocation was performed by a research worker separate from the assessors and the therapists.
Right.
So I think that's done
important.
quite well, yeah. And they also talked about sealed envelopes. Now, what they didn't say is whether whether they're opaque envelopes or not. So I think that would be something that I would mention. Okay, in terms of blinding, who wants to tackle blinding? What about that group at the corner there? You were marching ahead, so so let's hear the blinding. Fong, I can only see your name, so I'm sorry, I don't mean to pick on you, but I can't hear you. Sorry.
You can use mic like
So the assessor side, interviewer side, and the patient side. With the patient side, there are 3 types of intervention. They didn't blind the intervention because the intervention is totally different. One arm is about the medication, another arm is against. They talk and they solve the problem together. Right? So everyone know what intervention they get. Right? That's why they didn't blind the patient. Actually, they can blind even both all arms get all intervention. For the no medication, they can take a placebo, right? But I also concerned if they take placebo is okay, but the medication they take the fake talking, maybe another contamination.
Yeah, I agree with you. So I mean, we're laughing when you say fake talking, but you can actually chat to them about different things. You can just have a chat to them about the general chat. So yeah, I agree with you. That is possible to do. Yeah.
Yes, that I think is this is a time of the performance bias here, and another blinding at the assessor side. In the article, already mentioned about assessment of the outcome, and they show that the assessment were made by 1 or 2 experienced research interviewers who were blind to the type of treatment given. And in the assessor side, I'm okay with this. It's okay. The blinding and the detection bias is to me is low, but for the blinding and the performance bias is quite high.
Okay. So I'm going to go back to one point that you raised. You talk about placebo. Is it ethical in this context to have a placebo arm? So what are the patient groups we're looking at? And is it ethical to have a placebo arm? Is this a potentially serious illness where there is an existing treatment? Because that is the question. So if there's not an existing treatment already, and people, without the new existing practices, they get nothing, then I think placebo is quite acceptable. Now, if there's an existing treatment already, is it ethical to recruit these patients and not give them anything? So I think that's something that we need to think about if you're going to propose that they should have or could have done a placebo arm.
But I have concern in terms of treatment, in terms of a drug, because they mentioned that because of some introduction of some new thing, they changed the drug, paroxetine with the other drug. So is that have any kind of effect on the final outcome? That's again questionable, as the others themselves mentioned. But again, they mentioned that it's a kind of naturalistic outcome study, so that may kind of pacify the question of changing the drugs, one thing. Another thing in terms of assessment, he mentioned that he's okay with the blinding of the assessor, the experienced person, but the assessment also includes the subjective reportment of the patient in terms of BDI, Beck's depression, because patients themselves are scored, because patients are not blinded themselves, because they scored themselves, so that might kind of, I assume, but clinically I have worked in psychiatric workers, so it's really difficult to do it in them, but still there is always chance of introducing bias. So I think in our group we made it as high risk in terms of considering these points.
Okay, so let me just ask all of you, right? So what I'm hearing is you could either consider this as high risk of bias for the reasons that Bhavani has pointed out, or you might assess this as a low risk of bias because you're satisfied that the blinding assessors was the best possible way. They've done what they could. They've done the best in terms of the condition and the patient types. So let's have a show of hands. High risk of bias. Which group consider this has a high risk of bias in terms of blinding? Yeah. And who's grading this low risk of bias or not high risk of bias? So most of you are not making a judgment on this criteria. Wow, you're never going to finish a project. You're never going to finish a systematic review. You're going for high risk. Okay. There is no right or wrong answer here, so it's about judgment. And this exercise is to help make you think. So that's absolutely fine. Okay, so I'm going to move on to the next domain, incomplete outcome data. So this relates to. So we've covered selection, performance. Actually, we've covered blinding. So we've covered the selection bias and randomization, performance bias, which is related to blinding, and then detection bias. So we kind of touch on that as well. The next one's attrition bias. So what are your thoughts on attrition bias? So I'm looking straight ahead. That group hasn't really given us much. I haven't heard your voice yet, so yeah, what do you think?
I think it's high risk in attrition bias.
Attrition bias. Okay, so why do you think that?
Because there are a lot of dropout rate, I think so. I think nearly 30%. So I make a judgment like this.
Okay. Any other comments on the dropout? So the 30% of dropout. So there's actually, it's not just a 30% dropout, there's a differential rate. It's quite striking difference in terms of dropout between arms. So there is, I agree with you, there's potential attrition bias here. And did they give us any information on the dropouts?
Yes.
Okay, so what do we know about people who dropped out?
For group 1, a lot of patients cited that the treatment was not working. 10 patients out of the 30. So I think it's quite.
Yeah. But so it would be useful if we have more information on the disease characteristics of the dropouts between the group as well, in terms of why the treatment is not working for those patients. Now, the other thing that you may have noticed is the dropout over time. So for the 52 weeks, for the longer follow-up period, you lose a lot more people, and that's quite typical of studies. As the study go along, at 12-week assessment, you have a higher proportion of people still in the study, and as it goes further, then you start seeing a greater amount of dropout.
I'm not sure about the numbers because the patients completing intervention, patient completed follow-up. Because there is some differences in numbers, but I don't know how exactly. Because if you see in the first thing,
in two arms, basically they have given that the patients completing interventions at 25 and patient completing a follow-up till 52 weeks at 25. But in the second arm, they have mentioned that patient completing interventions were 32. But for the 52 weeks completion, only they have mentioned N is equal to 28. So what about the 4?
Yeah.
And even the 12 weeks, even for 12 weeks, it is like the patients allocated with problem solving with nurse. 6 weeks is 39, 12 weeks is 36. But patient completing intervention at 12 weeks is 32. So I don't know, the numbers are not.
Okay, 2 arms, there is a problem.
Yeah. So I mean, the information here is incomplete. So you can get a lot more information. But what the question you should be asking is it going to be affecting the treatment effect that they're reporting?
No.
Yeah. So is it going to overestimate or is it going to underestimate the treatment effect? Or is it going to have an impact on the treatment effect, but you don't know what direction? So that's what you're looking for.
One more question, because it would have been better if they included number needed to treat kind of approach. Because those who dropped out, if at all they would have included, because they all their calculations were according to those who are finally there, not those who are dropped out because of XYZ reason.
Yeah, so it was an intention to treat analysis.
Intention to treat.
Yeah.
If because that approach is not there, can we correct us with, because the kind of results what they're mentioning.
If it's not intention to treat, then I think, potentially it will have an impact on the estimated treatment effect. So if it's not intention to treat and you're seeing a large amount of dropout, then you would, I think the study would have either overestimated or underestimated treatment effect. Yeah. Okay, so other sources of bias. Yeah, okay.
I just have a little bit questions because they showed us there is a not known reason for the withdrawal of the patients. I think it is maybe the reason for the high risk attrition bias.
What was not known?
The unknown reasons.
Unknown reasons for dropout.
dropout.
Yeah. So, but the problem is, I mean, you're absolutely right, but also you can see why this has happened because often people just don't turn up for their assessment, and you will never find out why because if they never come back. So it's not always possible to record every single reason. So you can see why there will be reason unknown for dropout. It doesn't necessarily mean there's a low risk of bias, but it just means that you can understand that it is highly possible that they're not trying to hide something. It is simply because they just don't have that information. Other bias, has anybody go on?
I'm thinking if the difference of the training or capacity of the GP versus the nurse would have affected because it says there that the nurses were experienced in problem. They were experienced healthcare providers in terms of problem-solving therapy, whereas the GPs only received theoretical training, although they have been trained with an experienced therapist. But I think that they did not receive an equal amount of training package, so it might have affected in terms of their ability to provide this. And I think it's important because the main point of the result of this study is saying that regardless of who provides the training, it doesn't matter. I mean, they're all both.
I absolutely agree with you, Yen. I think that is a potential bias that there's not a. So what they could have done is they could have used a standardized protocol, and that would have helped And this is what we term. Did they? Let me just see. So this is what we normally term a pragmatic trial. And done in these settings, typically you have to go down this route. And so the lack of a treatment protocol is often one of the problems in pragmatic trials, and yeah, it can lead to potential bias. And also relating to that, I think some patients receive treatments at home, others receive it at health centers. So again, that's a potential, that may have potential influence on treatment effects. Any other potential bias that you spotted? Treatment sessions, how often do they get treated? Yeah? There's a range between 1 and 7. So again, that could be a potential source of bias. What were the drugs that they receive? Different dosages are given for the antidepressants. Now, in the paper also said that the GPs were free to provide whatever treatment was appropriate. And they don't actually say what they were. So it could be possible that one arm was getting something more effective than the others. So again, that could be another source of bias. Okay, so are there any comments? Yeah.
But just even suppose they are not mentioned that appropriate treatment one arm has got as per the physician's own judgment, okay. But the results told it informs that even though the one arm where no treatment has been given, it is equally effective, right? So if we consider these two things, then is there any need to again go through and see that whether the bias is really included or not?
So
it's necessary to go and see or think.
Okay, so you're saying that the results unexpected. So I think it's all down to your assessment of the methods. So if the methods are satisfactory, then you have no evidence to suggest that the results are inappropriate or wrongly reported. So if if you're satisfied with the methodological approach and you believe that they've done everything according to what they've said, then sometimes results are unexpected. Yeah. But in this type of studies, it's very difficult because there's a lot of there's no clear protocol. You cannot really strictly implement a particular intervention here. So could this study have been done differently and better? I think it's hard to say. Could they have reported it better? Definitely. Yes. They could have given us a lot more detail. So I'm very, very pleased to see you being very critical of a paper published in a very high impact factor journal. I'm very, very proud that none of you have said, oh, it was published in the British Medical Journal. I think this is a very good paper. So I'm very, very proud to see that you haven't gone down that route.
So ultimately, then the decision is that we can include this paper for meta-analysis.
So
decision.
Okay, so this is yes, but this is an important point. So this paper, if it was in your systematic review, you've selected it according to your selection criteria. So this paper, if it's in your review, it fits the PICO criteria, and so if you now decide that this paper is of poor quality, for instance, I'm not saying that you have, then you reject it and not include in your review. So it's not wrong. Some people do that. Some people do systematic review and meta-analysis. They go down to this stage and they will exclude low quality papers and only summarize the high quality papers. Now, I personally don't think it's very good practice. I think the purpose of the systematic review is to have an understanding of the totality of the evidence. So you may want to do a sensitivity analysis and see how much impact the low quality papers have on your overall estimates, and report it that way. And often it might not have an overall impact, because you might find naturally the low quality papers will end up having lower weighting because it's a smaller study, and which underpowered, which then will lead to high risk of bias. And so you know, naturally it does get accounted for by the process of systematic review and meta-analysis anyway. But I think to reject evidence based on quality at such an early stage and not being inclusive and talk about the potential impact is quite restricted. So I would advise you not to reject it, but report it, and maybe you know, do an analysis with all the studies and another one without the studies as a sensitivity analysis. Yeah. Okay, so I'm going to go, and I'm now going to talk briefly about observational studies. Now, I know some of you have a background in epidemiology, and others are familiar with observational studies anyway, so I'm not going to spend a lot of time going through the detail, but potentially we can do systematic reviews on observational studies as well. So I think it's good to have a reminder of the potential bias of observational studies. So, for instance, observational study, patients are allocated to groups by exposure status. So an example is smoker or non-smoker, and then you want to assess the outcomes. And you cannot really ethically randomize people into smoking or not smoking. So that's why there is a role for observational study. And you can't really randomize people according to risk or according to a genetic disposition. So observational study has a very important role. But in observational study, investigators have no control over the exposure status. So we can start with cohort study. So just a reminder, cohort study is when data are obtained from those who have been exposed or not exposed to a factor of interest, and your patients or your participants will then be followed up over a period of time, and then you record the outcomes of interest. So it's commonly used to compare incidence disease in one or more study cohorts. So for example, the incidence of heart disease in smokers and non-smokers, if you want interest in comparing them. So that's typically the type of study. There are huge advantages from cohort study. Ethically, it's safe, you're not intervening, you're not giving them something. You can match your cohort. You can have a comparative group by matching your cohort. You can establish the timing and the directionality of the events, and you can standardize your eligibility criteria. So similar to randomized control trial in terms of your inclusion criteria, you can standardize that for your cohort study. Disadvantages are controls might be difficult to identify to match the cohort that you're interested in. And the other disadvantage is hidden confounding. Confounding is a huge issue in observational studies. There are lots of statistical techniques to adjust for confounding, but there are always unmeasured confounders that you can do very little about. And blinding is difficult, and typically there's no randomization with cohort studies or observational studies in general. Case control studies, you identify patients with a certain condition, outcomes of disease, and then you identify an appropriate control group without that condition. So usually the challenge here is match controls, so you need careful consideration on how you match. So nowadays you match on multiple criteria. So I think historically you see very minimal matching just on age and sex, and that's not really not enough. You really need to try and match the two groups with as many relevant criteria as possible. And in a lot of epidemiology studies, matching underlying comorbidities are very important. And then the information is obtained on whether the patients have been exposed to the factor that you're interested in. Advantages of case control study. It could be relatively simple and cheap to do. And you can use historical data. So it could be retrospective. The problem is potential recall bias, depending on how you're collecting your outcomes data. So it could be, and if you're relying on retrospective data, it can be incomplete. Missing data is a big issue in a lot of the observational studies. And also the selection of control group is quite difficult. It's just to make sure you have an appropriate selection of control group. So these are case control studies. And then cross-sectional study, commonly used to estimate prevalence of a disease or risk factor, looking at the relationship between a disease and other factors of interest in a specific population at a specific time point. And you measure both exposures and outcomes at the same time. So for instance, I was involved in this cross-sectional study, an international cross-sectional study on deep vein thrombosis. And what happened was that we chose one day, and we had multiple sites across different countries, and the clinical investigators and local sites went to the hospital wards and recorded data on everybody who was in hospital on that day with a deep vein thrombosis. So that's one example that we, in terms of the cross-sectional study. So again, it could be relatively simple and easy to do, and it's ethically safe, but the disadvantage, like in many other observational studies, is you can talk about the association, but you can't establish causality based on observational data. Again, you could have recall bias and confounding bias. So that's common across different types of observational studies. So confounding, it's impossible to rule out, really. You cannot be clear of confounding no matter how sophisticated your statistical adjustment might be. So you just have to accept that, and that's a limitation. And it occurs when an additional factor or variable differs between groups and is associated with both the exposure and the outcomes of interest. Now, I do have a short video explaining confounding, but I think this is actually quite a long video. So I'm going to leave you the link to the website, and it's worth having a look. And I think on this video she gives a really, really nice example and explains the confounding very, very clearly. Now, to adjust for confounding, you can make a systematic effort to identify confounders. So through matching is one way, appropriate matching. You record data on confounders, you measure confounders, and you present data on distribution between the groups. So it's like your table 1 and randomized control trials that will give you a bit of information. And you can adjust through statistical analysis using regression or stratification. But remember, you're only able to adjust for what you have measured. You can only adjust for the variables that you have data on. And there are other study designs that try to address this. So natural experiment, regression discontinuation, or the use of instrumental variables. So these are more advanced statistical techniques for adjusting for confounders. And it's typically, again, used in public health interventions where it's almost impossible to do randomized control trials. So natural experiment and regression discontinuation is very commonly used in evaluating public health interventions, when it's normally what they do is they look at before and after. So so for natural experiment, for instance, in Scotland years ago we introduced a smoking ban in public. So in order to evaluate the effectiveness of the smoking ban, we only have observational data because there's no randomization between groups. So we looked at data before the policy was introduced, and then we looked at the data on policy after the policy was introduced using a natural experiment approach. So identifying risk of bias in observational studies, what are we looking for? So you need to think about whether the data are prospectively or retrospectively collected. If we talk about potential recall bias, missing data, how the patients are selected. Is there potential selection bias in terms of the observational study? So look at the inclusion criteria. How did they select their cohort? And how did they select their matching comparator group? So do they have valid, reliable measures of exposure and outcome? So this is similar to randomized control trials. How do they define outcomes? How do they measure the outcomes? And also, how do they do that with the exposure factor? You can do assessor blinding in cohort study. So you can blind assessors. So have they done that? That's good practice in observational study. So have they made efforts to identify and measure confounders? And the distribution of confounders between the groups. Did they make comments, and did they do analysis of that? And were there any statistical method used to address confounding? So these are some of the criteria you can use to help you assess potential risk of bias in observational studies. Now, of course, we have a tool for this. So I always say that the assessment tool is like an industry now. There's a tool for everything. There's more than one tool for everything. And this is a tool developed, again, by most of these guys, Jonathan Stern and Julian Higgins and the rest of the colleagues are active methodological experts for the Cochrane collaboration. And the Robbins Eye tool is developed within the Cochrane family. It's a tool for assessing the risk of bias in randomized studies of interventions. So again, have a look at this paper. But word of caution, this is actually quite a difficult tool to use. You really need to have good understanding of observational studies in order to answer the questions you need to answer well. So while this is a really important and useful tool, it is quite a challenging tool to use, and it's quite a long tool as well. So I'm going to finish by talking about how you incorporate the results of your critical appraisal into systematic review. So the strategies for the analysis, so you restrict your studies, as we just talked about, to low risk of bias. So that's one approach that has been recommended in the Cochrane Handbook. But I think in the next update, they probably will begin to suggest that you should have the totality of the evidence before you start excluding studies. You can present multiple or stratified analysis, which is very similar to the sensitivity analysis that I was talking about. And you should present, or you can present all studies and provide a narrative discussion of the risk of bias. And I think that approach is the most transparent. So this is the grade representation of quality of evidence that is often used, mostly in clinical guidelines. So first of all, you rate your quality of evidence in terms of high, moderate, low, or very low quality. So you can use a diagram on the right over there. And based on your evidence, if you make a recommendation or draw a conclusion, how strong is your recommendation? So it's like a two-stage approach to presenting the results of your quality assessment in relation to your recommendations. So the grade tool is also a very useful tool. And this particular, the strength of recommendation, is particularly relevant for clinical guidelines, where they always make a very firm, succinct recommendation at the end of the evidence synthesis. This is another way of presenting quality assessment. So you can see these are the criteria that we've talked about today, and you've got low risk, unclear risk, and high risk. And basically, they demonstrated the proportion of studies with low, unclear, and high risk, like a traffic light system, red, amber, and green. So you can see very quickly and easily from this that there are very few criteria that has a high risk of bias. The most relates to blinding. These studies that they have in this review did very well on reporting, very little, low or unclear risk of bias in selective reporting and so on. But the problem here is there's a large area of unclear risk of bias. So unclear risk of bias does not mean one way or the other. But that tells you quite a bit of detail about the risk of bias of all your studies. So this is why I always advise against using a single number, a single value, because you don't actually know where the limitations are. But if you present it this way, it's very clear where the limitations are. This is a way. This is another way of presenting risk of bias, and I think the Cochrane handbook probably. Yeah, it came from the Cochrane review, and Cochrane reviews typically present it this way. And there's even finer detail because you've now got the studies broken down, all your individual studies. And then down across this way is your domain for risk of bias. And just, so looking at this, you can see very little high risk of bias, quite a good distribution between low risk and unclear. So you can start thinking about how do you write this up. So first of all, a general impression, and then you can tell, then you can see which studies are particularly, so these studies have low risk of bias on all domains. So these are the good high quality studies. And then you can look down the column to see where the problems are. So here, randomization, well, only one study. So you can see, you can set, if you have a table like this and you have a column that's all red, then you know where the high risk of bias is. Now, so it could be that the study that we're looking at. So we're doing a systematic review on that type of study. It may be that none of them were able to blind. So you'll have a red column all the way down here. But then you can explain it. You'll be able to explain why. So this is again a very clear way of presenting your risk of bias. So so in terms of meta-analysis, what you can do is you can do stratified meta-analysis according on how you categorize the potential risk of bias. So you can stratify it by looking at all the green studies separately. So these are your best quality studies. So how does that differ from including all the studies together, or by excluding the high risk studies? So that's one way of doing it. You can also weight the study according to the quality. So you can manually apply a weighting in your meta-analysis. So that's another way of doing it. So. Or you can give a narrative description, as I've shown earlier. So in conclusion, critical appraisal is necessary, given evidence that aspects of study design and conduct influence the treatment estimate, the effect estimate. So remember, the question you're asking yourself is, how does it impact the overall reported estimate in the study, and in what way? There are lots of tools available, and there are trade-offs between them. So some of them are really comprehensive with lots and lots of questions. Others are much easier to use, but then you lose the detail. So you need to strike a balance when you're choosing between tools. So I encourage you to go and have a look at the Equator website and pick one that you think is appropriate, and benchmark it against the statement of quality of study, against the consort statement, for instance, if you're doing randomized control trials. So if you're picking a short tool, look at the consort statement. Is it short? It's fine that it's short, but does it cover all the important elements? And presenting results is essential and useful, and there are different formats for you to present the results. So I've just shown you some examples of how you can present it. So there are no rules on how you should present your risk of bias assessment, as long as it's transparent and understandable to the reader. So you can be creative. You can create your own way of presenting the results. And I'm going to stop there. So do you have any questions? No? Okay, so I hope that was helpful and is useful for you when you go and do your systematic review. So remember what I've said before. After a session like this, people often go and become really critical detectives. So about striking a balance and looking at the totality of the paper as well. You need to read through the whole paper and then think about the critical appraisal, because the issue with reporting and limited word count is a challenge. So whether it's because they haven't been able to report it for various reasons, or whether they haven't actually done it well, it's something you need to make a judgment on. Okay, thank you.